It's good to see everybody. Maybe you guys met Luna, my companion in my basement. I don't know. She's back there still. Oh, there she is. Otherwise, I've been spending a lot of my time down here when I'm not running around somewhere else. Let me tell you a little bit about myself, but then very little. I really think this will be best if you guys ask me questions that are on your mind, and we can talk about many different topics related to public health. So my background is I'm a pediatrician. So I went to medical school. Actually, if you go back before that, I went to college. And then I spent a year in Central America working on public health projects in Guatemala and Costa Rica. And then I came back to medical school. I went into a pediatric residency and finished that. So I'm a pediatrician. And I did a general pediatric fellowship. So 2 more years after my 3-year residency, where I studied a little bit of health policy, some public health, clinical teaching. I saw patients. And then I went from there to a government career. And so I had 15 years in the public sector. So I worked for, first for a member of Congress named Henry Waxman, who is considered by many people to be the most effective and certainly one of the most prolific legislators of any legislator at any point in US history. And he was responsible for laws like the Clean Air Act and the Clean Water Act, the Ryan White Act for HIV, the Hatch-Waxman Act for generic drugs, created generic drugs, vaccine compensation, the Affordable Care Act, so many different laws. I worked for him for 5 years as a pediatrician while I was seeing patients on the side. And then I applied to be the health commissioner of Baltimore City. And I became the health commissioner of Baltimore City in 2005. I did that till 2009 because in 2008, I got involved in President Obama's first campaign. And so they put me up, I was like a debater for President Obama at different, for candidate Obama at different events. And I would debate against people who represented John McCain. And it was not like the Today Show, here's Josh. It was more like the National Italian American Foundation annual meeting. So it was like 4 rungs below the Today Show. And they would be like, here's Josh representing the Obama campaign, and here's some other guy. And I would get up and say, like, I asked him beforehand, and he's never been to Italy. So, you know, that would be like my thing. But anyway, I got very involved in the campaign. I got involved in the transition, and I wound up as a presidential appointee at the Food and Drug Administration. I was the acting commissioner of the Food and Drug Administration, and then the principal deputy with Margaret Hamburg as the commissioner. I did that for 2 years, and then I came back. I was always living in Baltimore. I came back to run the state health department as the secretary of Maryland's health department for 4 years. And so my public sector career was 2001 to 2015. And then I came over to Johns Hopkins. I've been at the School of Public Health since, teaching and doing different kinds of projects on a whole bunch of issues, mainly domestic, but some global. My main issues are in now COVID-19, but I've also I've done a lot on the opioid epidemic. Somewhere here, do I have a copy? I have a book that I wrote about the opioid epidemic with my wife, called The Opioid Epidemic. And then I also teach about public health crises. So I have a class where we just talk about public health crises. I wrote a book called The Public Health Crisis Survival Guide, intending to help people in the field of public health. I work on violence as a public health issue, on environmental issues, on adolescent health issues. So there are a lot of different topics. So you may have met along the way some specialists, so that they're like medical specialists, you know, they're people who are like, I only work on the left atrium, you know. Then in public health, you have specialists, you know, they're specialists in a particular kind of nutritional deficiency or a particular type of public health intervention. But I'm a generalist. I'm sort of like a primary care doctor, but for public health. So I've worked on many different issues. I've worked at the congressional level, which is legislation. I've worked state health department, local health department, federal government. So I've done a little bit globally. So that's pretty much my background. And I find these sessions very difficult if what I'm doing is sort of just talking to myself, you know, and hoping people are listening, but much more engaging if people have anything that they want to talk about. So and I think Siam said, maybe there are questions about careers and how you have careers in public health, about controversies in public health, about questions you want to know about COVID, this, that, or the other. Happy to answer your questions about that. Really, this is your time. I'm totally happy to go in any direction, and hopefully will be entertaining enough. I was just saying, I don't know if I'm going to be as entertaining as Dr. Mike, but I will do my best. We have a podcast called the Public Health on Call podcast. We're closing in on 2 million downloads. Dr. Mike brushes his teeth, he gets 6 million hits. So I'm we've been working for 4 months. So we've got a ways to go, but I did interview Dr. Mike for the podcast, and we're doing that one as a video, not just an audio. So he was pretty nice to do that with us. So, but in the podcast, we've talked all about a number of different issues. We've talked about racism and the impact of racism for health in great detail. We've talked about COVID from many, many different angles. So I feel, based on having done a lot of those interviews, I know more than I probably should. So I'm happy to talk about anything.
Hi, my name is TJ Suoni. I go by TJ, and I am from Kansas. And I just have a question about hydroxychloroquine, because it's just been, I guess it's come back up again in recent days. And the FDA put out an announcement that, hydroxychloroquine should not be used as a treatment for COVID-19. But I had two questions. One of them, the first one is, can hydroxychloroquine be used as a prophylaxis instead of a cure? And if some people are getting better, better using hydroxychloroquine, there's several other countries that are trying to use it, should we try to figure out which groups of people will be able to tolerate hydroxychloroquine? For example, people who have already been taking it in the past for malaria, for an example.
Sure, good questions. So hydroxychloroquine is a medicine for malaria. Hydroxychloroquine, Plaquenil, is used for lupus and some other autoimmune disorders. It's medication that a couple people thought might be helpful for COVID-19. Now, the Food and Drug Administration, which, as you know, I work there, they have a couple approaches to medicine. So one thing they can do is they can approve a medicine for something. If you've heard, this medicine is approved for stomach cancer, then, you read the instructions and it says there's been a study and here's how it helped the patients with stomach cancer. And the standard for approval is that the benefits are known to exceed the risks. So if the benefits are exceeding the risks, then, and that's clear usually on the basis of a randomized control study where half the people got the medicine, half the people didn't, more or less, and there are two of those studies showing a benefit, and the risks aren't serious, then FDA will approve that. And that's called approved, okay? Now, FDA, in an emergency that's declared by the Secretary of HHS, and has COVID been declared as an emergency? Yes, it has. Okay, so in an emergency, FDA can authorize, so that's a different verb, not approve. They can authorize a treatment. And they can authorize a treatment with a different standard. So the standard for approve is that the benefits exceed the risks. The standard for authorize is that the potential for benefit exceeds the potential for risks, or is likely to. So it's sort of a guess, I think, based on the evidence that we have, that in this emergency, we're going to give this a try, okay? Now, the very first authorization in an emergency was signed by me when I was at FDA. And the situation was that it was the 2009 H1N1. And during that time, there was something called Tamiflu, which you may know is a treatment for influenza, but there was no dosing for Tamiflu less than 1 year old. So the question was, what should be approved? Could it, what should be used? What dose of Tamiflu should be used for little babies? And so we had a great team at the FDA, and they said, look, we've never done this study, but based on everything we know about how Tamiflu works and how little babies metabolize, we think this should be the dose. I don't remember the exact dose. And so I signed an authorization. So there was an approved dose over age 1 and an authorized dose less than age 1. So authorized, not the same as approved. So that's a little bit of background for hydroxychloroquine, because what happened was there were some people who thought it was a good idea. And they basically had treated some patients with hydroxychloroquine and felt like those patients didn't get that sick. What's the problem with that logic? A lot of people with COVID don't get that sick, right? So like if I saw a patient and I did a little dance and they got better, I'd be like, oh, I did a little dance. I'm the magic dancer, So how do you know that it actually works? How do you know that it was the hydroxychloroquine that caused a patient to get better? And ultimately, that's why we do randomized studies where we give half the people hydroxychloroquine and half the people placebo, and they don't even know which one it is, and then you see who did better. So it's really good evidence. But just having a doctor going like, I don't know, I think it works. I had a patient once, not that strong evidence. So there was sort of this weak level of evidence. And who was very excited about hydroxychloroquine at that point in time? Anyone come to mind? Orange hair, lives at 1600 Pennsylvania Avenue. Okay, that guy, very excited, talking a mile a minute about hydroxychloroquine. So during that period, he wanted FDA to authorize. Nobody was saying approve, but just authorize it, FDA, just authorize it. And did they do that? Do you remember? Did FDA authorize hydroxychloroquine when there was just a little bit of evidence?
I think so.
Yes, they did, correct. So FDA authorized it. And there were a lot of people who went like this, oi, there was never any good evidence. FDA shouldn't have authorized it. Some people said, of course, it might work. There was somebody who had a good outcome. Let's use. So authorization is actually pretty new. Approval, there's like nearly 100 years of history, but authorization is pretty new. So people are arguing what's the right amount of data to authorize. So you had these case reports. You had a little bit of a study from China that showed potentially a reduction in the virus, but it was not clear. And FDA went out and authorized it. And then the use went bananas. Now, one of the consequences of everybody using hydroxychloroquine was that the patients who really needed it for their lupus couldn't get it, which was, a huge bummer for them. Some of them were told, thank you for your sacrifice. They were like, I didn't want to sacrifice. Why would you take away my drug that's saving my life for a potential use? You don't even know whether it works or not. So that, I think, was not very fair to them. So here we are in this situation with a lot of use. And so what I was interviewed a lot on TV, and people said like, well, does it work? Does it not work? And I said, we don't know. We're not going to know until we do a study. We've got to do a good study. And so the studies started coming out. And what did they show? The best quality studies. No benefit. And so there's no benefit for use. And when that happened, the higher quality studies showed no benefit. The FDA revoked its authorization, said it's no longer authorized. That did not make a certain someone happy when they did that, but it made a number of us breathe relief, because we think, look, authorization shouldn't just be like someone's got an idea. It's really got to be based on data. And when the better quality studies showed that this particular medicine didn't work, that's it. So there's no reason to be taking hydroxychloroquine for COVID. There's no basis for believing it works to prevent COVID unless it's in a study and you've got some different reason to believe it might work. Like if, let's say you're a doctor, you're like, I've got this crazy idea that, only people who are left-handed with type A blood, maybe I've got an experiment in the lab, and I think because of that, hydroxychloroquine, I'm going to look for those people, and maybe we'll test it in those people. If you could convince someone that there's a real justification for that, then you should do a study. You shouldn't just announce to the world that people should take it. So my view is that FDA, maybe they leaned in a little too fast to authorize hydroxychloroquine, but then when better data showed up, they backed off. Now, why is this so important now? What may or may not get approved this fall? Vaccine, correct. So a COVID vaccine could be approved. What is the standard for approval? Benefits exceed risks, right? They're known to exceed risks. So they're doing studies right now where half the people get the vaccine, half the people don't. And the FDA put out a standard for approval of a COVID vaccine. What is that standard? Anyone know? A COVID vaccine has to do the following in order to be considered effective. It has to reduce the chance of your getting COVID or getting very sick with COVID by 50% or more. If you don't have that in your vaccine, FDA will not approve it. It's a very clear standard, and I can put in the chat the link to the document. It's very readable. How this is guidance for the companies. This is what you have to do for us to want you to have a vaccine. Now, for you to have an effective vaccine, you've got to meet this guidance. What's the standard for authorizing a vaccine? Remember I talked about approve versus authorize? No clear standard, right? No clear standard for authorizing a vaccine. And if you look at this guidance, I'll pull it up. FDA guidance, vaccine, COVID. If you read this, there's a lot of details about approving a vaccine. Another word for approval is licensure. A licensed vaccine is an approved vaccine. Those are largely synonyms. But authorized is not the same. Authorized means the potential for benefit is likely to exceed the potential for risk. So could the FDA authorize the use of a vaccine that is not yet approved, meaning the benefits are not clearly shown to exceed the risks? FDA has the legal ability to do that. And maybe the government will say, it's 25% effective, we'll authorize it. We're not going to approve it. Or maybe they'll say, we don't even know whether it works, but it does seem to improve, to cause antibodies. So we'll authorize it. Anything that's done with an authorization that's not an approval isn't really the usual gold standard. And so I wrote an article about this where I made the point, or with my co-authors, we said, if FDA is going to authorize instead of approve a COVID vaccine, they have to be very clear with the public that they don't have the evidence yet to show that the benefits clearly exceed the risks. They have to explain very clearly why they're authorizing it, and they should require that the person give informed consent before they vaccinate people. Because people shouldn't be confused that an approved vaccine is there when it's just authorized. Anyway, just to extend the point about authorization and approval. TJ, is that helpful?
Yes, it is. Thank you.
Okay, no problem. Other questions?
So when you went into the political public health sphere, do you think your own clinical, not like specialization for pediatrics helped you? Because going into that type of sphere is kind of what I want to do too, but I don't know if it's something that's recommended or something experience-wise which would be beneficial to also get a specialization in something beforehand and then go into maybe like a public health background like that, or if you think that experience like that is not only beneficial but highly recommended for someone as well.
Yeah, it's a good question. So in my mind, I think of clinical work and policy work as different things. You can get different answers from people. But, medical school, for example, is hard, and clinical training is hard, and so I think the reason to do medical school or clinical training is because you really want to be a clinician. There's part of you that not only a clinician necessarily, but that you really like clinical medicine. Like sometimes people come to me and go like, I know I never want to see a patient, but should I go to medical school for my credibility in the policy sphere? And I go like, please don't do that. Let somebody, go to medical school who really wants to take care of patients. There are plenty of ways to have enormously influential careers without being a doctor, So I thought about I knew I was interested in policy. I went to medical school. I totally love kids. I was like a camp counselor. I have a little brother and sister at home. I was a camp counselor. I just love kids. And I thought, well, I could go into family medicine, then I'd be better placed, or medicine pediatrics, to do maybe other policy things. And then I was like, I just want to be a pediatrician. That's what I want to do. That's how I kind of figured that out. And I love clinical pediatrics. I haven't done it in a while, but that's another story. But I think I'm crawling my way back. I'm still boarded and everything. But truthfully, I think the clinical part is what you love to do clinically, and then you can switch into policy. Once you switch into policy, there are just not that many people around. I mean, policy is a much smaller area, and particularly depending on what you want to do, it may be perfectly fine. Like in my case, I'm a pediatrician, but I was doing all kinds of policy for people of all ages. Now, there are probably some exceptions to that. Like if you want to do policy on, transplants, it may be better for you to be a transplant doctor of one kind or another, than to be a general physician or something else. I mean, maybe that would help you if you were going to do that. But truthfully, I kind of feel like I could have gone into transplant policy if I really wanted to. And if I did a good job on that, it would sort of be on its own merits, not because I was clinically involved. Now, a separate question I get sometimes is, does going to medical school and being a doctor help me in policy? Does it help me, And I think in some weird ways, it has helped me. And one of those weird ways is that I'm a good listener, because you have to really listen to patient and the parents. What I love about clinical pediatrics is talking to parents about their kids. I love playing with the kids, that's fun. But I really love talking to parents about their kids. One of my favorite things to do is when you have a little baby who's just so oriented towards their mother or father in the clinic, and you say, like, just look at how that baby is looking at you. And then the mom always smiles, or the dad always smiles. I just love that, And then you can talk, like, what's it like to be a parent? What do you want for your child? It's a really special relationship. So I totally, love that part. But you have to listen. And so I listen a lot. When I'm in policy, I can be a good listener. But the other thing is, I had a reputation in pediatrics as the doctor to call when the parents were angry. Why would parents get angry? I was in the hospital, and sometimes the parents would get really angry. And they would be like, I can't believe this is supposed to be a good hospital, but you're supposed to be taking the vital signs every 6 hours, and it's like an hour after you're supposed to take it. And what if something happened? And this is outrageous, and I'm going to call my senator. And, and they would get so upset. And a lot of the people in the hospital would say, God, those parents are just, really in a bad mood, or some of them might say, like, those parents, stay away from them. They're just angry. I would think to myself, those parents are scared. They're acting out. They're acting out because they're afraid of what's going to happen to their kids. And I would go in there and I would say, like, I'm worried about your child too, And then we'd just have a serious conversation about it. There was one time when there was an intern who I was working with, who, you can't see this because this is like distorted, but I am not a big guy. This intern though was like, huge. And he like lifted weights, and he was like, twice my size. He was just like a brick. And he came to me and said, we have to call the police. And I said, like, why do we have to call the police? He said, well, because there was a dad in the emergency department who said that he was going to kill me. And so I consider that a threat, and I think we have to call the police. And I said, well, what happened? And he said, well, the child came in with a little bit of wheezing, a runny nose, looks like a case of respiratory syncytial virus. And I explained to him that the child did not meet any of the 4 criteria for admission. There are 4 reasons why we could bring a baby into the hospital, and this baby was 0 for 4. So there was no reason for me to bring the baby in. The baby had to go home. And when I said that, the dad looked at me and said, if anything happens to my baby when we take him home, I'm going to come back and kill you. So I was like, let's go down and talk to them. So he was like, oh, no, I don't want to go down. I was like, oh, no, it's okay. We're going to go down. Go down. You could see there's like the family is very upset. Everybody's upset. And they said, well, I said, what's the matter? This doctor said, wouldn't bring our baby into the hospital, and we're very worried about the baby. And I said, well, I'm the senior doctor here right now. I was 1 year older than him. You know, I'm the senior doctor. And at the end of this conversation, if you want to come into the hospital, I will sign the order. I just want to have one conversation with you. That's it. Whatever you decide, I will turn the keys over to you. You want to come into the hospital, you can do that. And then you can just see people just get calm down right there. And then, you know, okay, let's talk about what's going on with your child. Let's talk about what'll happen in the hospital. And in the end, I said, look, you can come in. If you go home, I'll give you my personal cell phone. You can call me anytime. If you want to come back, you change your mind, you just give me a call. We'll bring you right in. We'll go right up to the floor. You know, here's why I think it might be better, more comfortable for you to be at home. You know, we're not going to be giving any medicines because the side effects would be too serious given the level of illness. And we'll have to wake, you know, the child up every couple of hours, whereas you could go home and you could sleep and just call me if you have any questions, and I'll call you at 6 a.m. And they were like, thank you. You guys are so great. Goodbye, everybody. You know, they left. We talked to them at night. No problem. Now, so I had that like intuition. I liked doing that. And so that comes up a lot in policy. People are angry all the time. And they can be angry at you. You know, I've had people go on the radio and denounce me. People yell at me in person. I don't take it personally. I think, why are they yelling? You know, I appreciate that they're serious. Like, to me, that's like this weird skill that comes out of my clinical training that turned out to help me a lot in a lot of these kind of political jobs. Because I thought, Trudy, you said very nicely that I've had both. My jobs have been political public health jobs. And so you have to be prepared for people to be angry at you sometimes and not take it personally, not feel it so personally. And that's hard sometimes. Other questions anybody has?
I can ask one, I guess.
Sure.
So with your background in pediatrics, like one of the biggest conversations I think we've hinted at a couple times is the reopening of schools. So what are your thoughts on the reopening of schools, obviously in terms of COVID-19, but also of like the physical and mental health of children?
Sure, thank you for asking that. I'll put a article that I wrote recently on this topic in the chat if people are interested. So my personal views is that we have a dilemma here. The dilemma is that kids really, particularly young kids, really need to go to school. And it's not very healthy for them to be stuck at home. Not from an educational perspective, where like online teaching kind of sucks for young kids. Particularly, it's not helpful from a social perspective. Kids really need their friends and the relationships that they have at school. It's not great nutritionally. We have an enormous amount of child hunger. 20 million kids usually get school breakfast and school lunch in the United States. They can't get them. 1/5 of all child abuse cases are reported through the schools, and reports have dropped dramatically. So you know that there are kids who are literally getting abused that can't be helped. So school is a really important part of kids' lives, particularly for younger kids. So that's one part of the dilemma. The other part of the dilemma is we're in the middle of a pandemic from a pretty serious disease. Kids don't get that sick generally, but some kids do. And then of course you have parents at home and you have teachers and others who could get quite sick. So, how do you balance those things? And the point that I make in the article that I wrote with Jennifer Nuzzo and other articles is that you have to balance them. And the way you can't say schools open no matter what. If you do schools open no matter what, you can have outbreaks in schools and people will get sick and you're gonna have to close the schools. And so you can't do that. On the other hand, if you say like, if there's any risk whatsoever, then we're not gonna open schools. That really, I think, underappreciates the enormous value of schools for kids. So our goal should be to open schools, but we need to do two things to do it. First, we've got to bring the overall number of cases down. And there should be a low level of transmission before you open schools. And second, you have to take precautions. And those are the kinds of things you probably read about. Reduce number of students, wearing masks if you can, cleaning more often. It's still school, but it looks a little bit differently. And so that may mean in some areas that not everyone can go to school every day, which is unfortunate. I mean, one of the things that I'm concerned about is just how, we have just a grossly unfair and inequitable education system in this country. And it's just getting more grossly unfair and inequitable during a pandemic because kids in some school systems, they can't go back to school at all, or they're going to get like 1 day with their teachers. And then private schools have like hired up a whole bunch of people and they're doing all these other things to make it more like regular school. You know, certain families where the parents can work at home can help the kids a lot more than other families where the parents can't. So I think that this is both at an individual level and a social level a real tragedy. And it's really sad that we haven't invested either in the money to help schools or in a serious commitment to reduce the spread of coronavirus so that schools could open. Other questions?
Hi, I have a question. So I'm Maren Thomas from Bethesda, Maryland, not the Midwest. And so I was wondering, like, what policies do you think that you made as part of the FDA that might have helped or hurt the current situation?
Good question from Bethesda, Maryland. I grew up not that far from there. The two main things that I worked on at FDA, one was transparency at FDA, where we created a big project to try to release more information about what's going on at the FDA and create the expectation that FDA shouldn't be like, you know, kind of a box that people can't see inside, but it should be explaining the principles of regulation. Like I tried to do earlier in this conversation, where I was explaining the difference between approval and authorization. Like FDA should be out there doing that now. We spent a lot of time, I wrote an article in the New England Journal of Medicine. It's really important for FDA to explain itself, because if it doesn't explain itself, people will always assume the worst. They'll assume there's some crazy conflict of interest that doesn't exist. They'll assume that they don't know who's making the decision. They'll, you know, FDA has an extra obligation to go out and explain. And I think the agency is not doing a great job of this right now, in part because the White House is sort of controlling a lot of what's going on in the scientific agencies, or at least the communications part of that. But if it were up to me, I would be following the principles that we put out in the transparency reports that we did. That FDA should be really, really explaining things, because people have a lot of questions right now. And if they're not explaining things, then people could hear from sort of people who are peddling in conspiracy theories or other things could really undermine things. The other major project I worked on at FDA is called FDA Track. You can look that up, which is performance management for the agency, which is basically ways that the FDA can manage itself, can track different aspects of the work that it does, and release that information, a large part of that publicly, so people can see what the agency is doing. And I think it would help the agency to use that structure to be able to explain to the public what stage of review each of the vaccines is in. I think there's a lot more that could be made public through the foundation of FDA Track right now that would be helpful. So I don't know whether the tools we made for the FDA are going to be used for COVID, but I think the transparency and the performance management tools could be.
Hi, Dr. Sharfstein. My name's Adi, and I'm from Pennsylvania. And I just had a question. What do you think would be some of the large-scale implications or pros that this global pandemic would leave on the field of like public health and global health? Because it's obviously had its mark on history and our lives today. So I was just wondering what it would mean for public health and global health in the future.
It's a good question. I don't think, let's just say I can imagine many different things happening, some good, some bad. So the good version of this kind of choose your own adventure would be that people wake up to the fact that we're not all just individuals, that we're, part of communities. And that if we do things together as communities for our health, then we're all healthier. Schools are a good example. Right now, you've got students are concerned about getting sick. Teachers are concerned about getting sick. Everyone's individually concerned, right? We're risk averse as individuals. But the entire community is like out going to bars, having a good time at the beach. We're not like controlling ourselves socially in order to make it possible for kids to go to school in parts of the country. So we have this like disconnect, and our social discussion, our community discussion is always, is very bankrupt compared to, what we think about should be done for individuals. And you can see that reflected in many parts of this response right now. So the positive outcome, in my opinion, would be to people to say, we need to invest in structures like public health structures, but not only, that keep us all healthy, that just help everybody. And that particularly help people who are otherwise at the greatest risk for serious health problems. Those structures, which we have let kind of wither on the vine, which is why countries like the United States are doing so badly. We have such weak public health agencies. Let's learn this lesson and let's invest in them. Now, that would be the good side. I'm not sure that that's going to be the lesson that people take from this. I'm concerned that, the sort of hyper-individualistic approach is going to keep us in this muddled middle with a lot of cases for a while. And then even when we get the vaccine, some people are going to take it, some people aren't going to want to take it. It's going to take us a much longer time to get through this. And in the end, people will feel like public health wasn't really that helpful, so why do we even spend any money on it at all? So I'm worried about that. And I think part of what I'm working on is for people to see the importance of those kinds of investments and capabilities in order to help everybody, rather than, just conclude that we're off on our own and, and have like tax credits for people to build sheds in the woods with 6 months of food or something, that you could imagine a world where it's just like everybody's off on their own as opposed to working together. And I think hopefully people will see the value of doing that. The countries that have much more of a collective ethic have done so much better. Other questions?
Can you guys hear me? I don't know if my mic's working.
I can hear you, Ria.
Okay, yeah, hi. My name is Ria. I'm also from Pennsylvania. So my question is, so once this pandemic ends, I don't really know how long it will be, but whenever it does end, what do you think, as a global community, our next step should be to be better prepared for a future pandemic?
Good question. Well, I think at almost every level we could be better prepared. So the first thing is detection of the respiratory viruses and honestly surfacing information about it really quickly. There was a problem at the beginning in China with that, unfortunately, and I think that led the virus to spread quite a bit more. I was actually in Taiwan in January when all this was happening, and somebody I was with said that they thought something serious was happening in China because everyone got quiet about it right before some big Communist Party Congress, and then it like exploded afterwards, and that was exactly the case that happened. So I think we need a better global system of surveillance and detection. Number two, we need, I think, to think globally about preparedness. Countries have to do better, but the world has to do better. And that includes a lot more capacity around protective equipment. What happened with protective equipment was just a disaster in the United States and other places, as well as much more capacity around rapid diagnosis. So we have to invest in diagnostic testing platforms of different kinds. So that the main testing for the virus is PCR right now, but there are other types of technologies that could be built out for that. So I think those are extremely important. I think that then, we're going to learn a lot about the vaccines and treatments. One of the capabilities that we need more of is to be able to do research quickly. It took an awful long time for some of those hydroxychloroquine studies to get completed. But if you have the ability to do research quickly, you could answer them much more questions much quicker and know a lot faster whether things work or they don't. Now we know of, I believe, 3 medicines have worked well in clinical trials, but it's taken a while to learn that. It hasn't taken that long, but we could have gotten the answers quicker. Those are some of the things. I hope that World Health Organization, needs to be strengthened in a number of ways. So I think some of the global mechanisms are really important. But again, a lot of these lessons still have yet to be learned because we're really still right smack dab in the middle of this.
Thank you.
Sure.
If no one else has another question, could I ask a second one?
Sure. And maybe let's see, last call for questions.
I have a quick question.
Okay.
Hi, my name's Morgan. I'm from Arlington, Virginia. I just graduated high school, so I am actually moving onto a college campus in about a month. And so I was going to ask you what you thought about colleges opening up and bringing students back on.
Sure. That's a good question. Where are you headed, Morgan?
I am going to Virginia Tech.
I heard about Virginia Tech going back on campus. Somebody I know as a child there. I think that it's going to be challenging. We know that young adults can really pass the virus on. We also know that you cannot pass the virus on if you wear a mask and you stay distant from people. So in theory, if you reduce the number of people on campus and you give people masks and people follow those instructions, then you could have a pretty low transmission if there's a relatively low amount, in the community. If there's like virus everywhere, it's gonna be very hard to keep off campus. But even if you have a little virus coming in, as long as people are distanced from each other and wearing masks, it's gonna be unlikely that a lot of people will get sick. On the other hand, if you have students hanging out in each other's rooms and sharing food and doing all the things college students do, like usual, then the chance of an outbreak is pretty high. And particularly if you allow different types of activities to happen, hopefully the colleges won't do that, but like choir, certain sports teams can be really hard to do this fall. So I think it's possible. You know, I have 2 college-age kids. Neither one of their campuses is open for them this fall. One of them is, they said, we don't want juniors to come back at any time this year. So he's got to decide, take time off or just take classes remotely. And his younger brother, the one who just graduated from high school, his college said that freshmen can't start till January. So first year. So they're waiting it out. But if their campuses had said, come back, I would want to know what their rules were. I would look at them really carefully, and I would do my best to try to get my kids to be worried enough. That's the job of parents, by the way, to get the kids to be, when it's completely quiet, to hear the voice of their parents inside their head, telling them to be careful. So that's what I would try to do. But it's hard because college is a very different kind of experience. So I would just say, you know, to definitely be careful.
Thank you very much.
Sure, good luck.
Thank you. It's a weird time to try to be moving anywhere, so hopefully it'll all work out.
Yeah, I'm sure they'll give you Virginia Tech masks, which will be cool.
I hope. It would be nice. Yes, they've made it mandatory and they have canceled almost all classes, so everything's mostly online.
Yeah, that's good. And again, it'll be you'll be telling stories about this for a while. You want to rapid fire last question?
Okay. This was just based on what John said before about the school systems. So I know with our system, a big concern admin has had is with elementary schools, because they're acting as a daycare as well for working parents. And also, I mean, obviously it's important for them to have outreach counselors in that way as well. So what do you think about social distancing for those types of ages as well? Because it's hard to keep masks on and keep them in separate areas as well. And if that's something that could be even risked with schools opening up, or if it's something important enough for that transition to even happen, sorry.
So you're talking about little kids?
Yeah.
And whether they can wear masks?
Yeah, and just like if you think social distancing is even a feasible like option.
I think at some ages it's very hard, like daycares, it's very hard. Some of the older kids, even first grade, second grade, may be able to do it better, depending. So you want to do your best without making the kids miserable at all. I think that's why you want to cohort the kids. So you may have like a particularly small group of kindergartners, maybe 10 kids or fewer, and it's the same 10 kids. So if one kid gets it, the other 9 might get it, but it's not going to go any further around the school because those kids are just stuck by themselves the whole time. And I think teachers should have the ability to opt out so that the teacher in that room should be in the low risk group. Anyway, well, good luck with everything. If anyone's interested in a public health career, email me anytime.